Okay, so our room 2 patient is an 85-year-old gentleman who has history of hypertension, DM, stroke, and ischemic heart disease with ACS in 2017 and 2018. He has recurrent admissions for cholangitis due to CBD stones, namely in February this year and also recently in September. The CT was done in August and also September this year, shows gallstones and sludges. The bile tree is prominent with small hyperdense stone inside the CBD. He's referred by outside hospital because failed ERCP for 3 times due to eccentric floppy papilla. They're still unable to achieve CBD cannulation despite pre-cut. Here are the reconstructed CT imaging, which shows you the CBD stones. So today we'll have US Rendezvous ERCP for this gentleman.
Okay, so we're looking at the bile duct. Looks like the bile duct has a tortuous anatomy, and let's turn this Doppler off, so we can see it posterior to the scope there. And it's very similar to that case that we just did there. Like the stone is subtle and back and forth. There's something there, but I still can't see. Here's some shadowing here. Trying to follow the bile duct down, we lose it. That's the pancreas duct there. And we're looking fluoroscopically. Anything you saw, guys, that is convincing right now that?
Do you need to go down into the second portion of the duodenum and kiss the papilla to make sure there isn't a distal stone? It was very distal on the MR, huh?
It's just this side. Sorry. That's okay. So it's pretty dilated here. So let me go more distal. Can we have the endoscopy image, please?
You think you want to put in a side wing scope and check it, the normal, because I think they attempted elsewhere.
Yeah, they attempted with the pre-cut 3 times.
Yeah.
But the plan, I guess, is to pass a wire and then.
Okay.
I don't know if there, Mouen?
I'm trying to be gentle here. They going through the. We're good. So reportedly there is a diverticulum as well. So I guess that was affecting our views of the distal duct. Can we put back the US, please?
So the presence of a diverticulum does affect the imaging for sure. It would be our practice, looks like you've fallen back, Mouen, but it would be our practice to always check with EUS before we embark on the ERCP. Sometimes these small stones can pass.
Can you put again
one of the
small
the really good
because I fell back.
of the integration of EUS with the ERCP.
So I fell back here. I'm gonna go back in. Give us the endo image, please.
Of,
just keep
getting
keep
this
the endo image.
view from the second portion of the duodenum. We did a study a number of years ago of gallstone pancreatitis. And I remember a case that I did. I did not see the stone on EUS, and but there was one on ERCP, and I missed it because I didn't look at the papilla specifically.
So this is the diverticulum here. What image do you guys have?
I'm sorry? We have the endoscopic image right now.
Okay, so this is, so we know it's an intradiverticular ampulla, so I'm assuming it's going to be here. Here we go. Okay, let's put back the EUS.
That looks like a stone, right? No?
No, we haven't seen anything yet. Rob, do you put a balloon on your scope to stabilize it here when you want the ampulla review?
Yes, I always use a balloon.
Yeah, so we don't have that here.
In Europe, it's not used a lot, but for this, particularly for this duodenal view, some shadowing there.
So I'm gonna pull back.
Was that pancreatic duct there?
Yeah, that's the PD there, yeah.
Okay. So the bile duct should be close. Right there. Right there's the bile duct.
Yes.
Yep. Up top. Somebody have an arrow for the audience? Yeah, there.
Can you show the what is the arrow? So I'll just put the caliper there.
It doesn't look dilated, does it? And
It is dilated there.
So there's your bile duct. Yep. Yep.
Okay. Just let's remove this. I'm just moving slowly here to look at the bile duct. It's pretty dilated here, Rob.
Did you measure it? It doesn't look dilated to me. Oh, there maybe.
But it can be dilated in patients with a diverticulum. Pull him back. We fell back here.
Short scope position or long scope position?
Fell out, huh? Yeah.
So here we're losing it,
Mouen,
and this is likely the diverticulum there.
Is there any role for, just putting like a small gauge needle into the bile duct and just doing a cholangiogram?
Yeah, I guess.
We're unsure with the diverticulum. We're not getting good imaging. You're still unsure. Rather than embarking on a complete rendezvous, just put a small caliber needle in and do a cholangiogram.
Yeah, I think that's a good idea.
Bothered by the tortuosity of the bile duct in terms of the rendezvous?
Yeah,
or?
it is a pretty tortuous bile duct here, and let me put Doppler on. You know, it's there's a lot of vessels anterior to it as well. But when we look at fluoroscopy, so this is a very favorable angle for a rendezvous.
You always do a distal bile duct rendezvous as opposed to going up into the stomach and
yeah, so
like you did yesterday?
If the intrahepatics are dilated, that's the easier approach because the wire tends to go south to the ampulla. But when the intrahepatics are not dilated here, so we try to get an extra hepatic approach. But let me get here. Let's get the needle, and we'll get a cholangiogram and then take it from there.
Think you're crossing any pancreas from this angle right here?
Sorry, can you repeat?
Do you think that from this angle that you have right now, do you think you're crossing any pancreas to get into the bile duct?
I don't think so. I'm just worried about crossing vessels here.
What gauge needle are you using?
We have a 19 gauge Boston Scientific needle.
Is there any reason to use a smaller caliber needle just to get the cholangiogram or no?
Very hard to inject through a 22, and I think in a non-obstructed duct, if the duct we prove is not obstructed, risk of leakage is really not there. So I'm not worried about that. Usually, if you puncture the gallbladder with a 19 gauge, it's an issue. So here I have to push the needle out a little bit because when I was in position, I couldn't push it out. Very stiff.
So it looks like you're in, huh?
Let's get fluoroscopy.
Can we enlarge the cholangiogram? Is that possible?
So we're filling the pancreas duct as well here.
So there's a long common channel, isn't there? Yeah.
So we're seeing the duodenum. I don't see a defect in the pancreas in the bile duct yet.
Very funky distal bile duct.
I mean, the whole bile duct was funky, Rob. Following it, you know. Okay, so let's.
From the diverticulum, I guess.
Yeah. So.
The contrast is freely flowing into the duodenum. Absolutely.
Yeah. Let's keep fluoroscopy on here. Fluoroscopy, please. Yep. So.
So
I mean,
there
I
is
don't see.
Clearly a filling defect. Is that a stone or just tortuosity of the duct? You see that?
The at the bottom, huh?
Yeah, at the bottom.
Yeah. It's really hard to tell. What is this? I don't need more contrast. Just give me some saline and let's pass a wire. So the duct dilates above that, Rob, right? So, okay, we'll get a wire. Can you help me pass it first?
The bile duct certainly empties.
Yeah.
Okay, I'll do it. We are. The
What wire are you using, Mouen?
so we're using the 025 angle tip Visi 2. So I'm trying to rotate it to go down. Okay.
Well done, Mouen. So if you get fired, you can always get a job in interventional radiology, I think, Mouen.
It's all about the wire, Rob. Okay, so let's just exchange here. Yep, go ahead. Go ahead. Push.
Push wire.
Needle is back. Yeah, let's just push. No.
Be careful. Killing me, Mouen.
I'm not hearing you guys.
We were asking you to push the wire. The wire was coming out.
Yeah, it's in good hands.
So during this exchange, there is unlikely to be any bile leak, Mouen, or do you try to hurry?
No, with just a needle puncture, it's not an issue in the bile duct.
Okay.
Once you dilate the track, Rob, then yes. So here now, I'm just gonna remove this. I'm just having more wire here so that I can exchange the scope. And now I'm just gonna exchange it myself under fluoroscopy, and we're gonna change into an ERCP scope.
Mouen.
Okay, so do you guys have both views, fluoroscopy and endoscopy?
We do.
Okay,
it looks
so
like
what
you,
we did,
you cannulated beside the guide wire.
Yeah.
You didn't actually use the guide wire.
yeah, so this is the easiest thing because, you know, pulling, getting the wire, first, we don't have a dedicated forceps to grasp the wire, so it can fall. And then if you have a snare, you have to pull it through the scope. There's a lot of time. It takes a little bit of time. So the easiest thing is to try to cannulate next to the wire, taking the direction of the wire fluoroscopically. And this is what we did. It was a hard bow up, actually, next to the other wire, and we were able to get in. So what we'll do now, we're going to take the initial wire out, so we can take the other wire out, that wire. Yep, don't be afraid, just take it out. And we can inject dye to get a cholangiogram. Yep, we can inject. We're injecting. So I'm suctioning here while injecting to get a distal cholangiogram. Keep
Is that
injecting.
a little bit of bile leak, or is that in the diverticulum?
Yeah, that's a diverticulum. And if there is, you know, these really don't once if there is no obstruction in the duct, Rob, then we're fine. I still can't see clearly a stone. So what I'm going to do here is, so obviously this patient had the gallbladder is in. So we're gonna do a sphincterotomy and sweep the duct and get an occlusion cholangiogram. And I think if we decompress here, it's good to make sure there's no leakage from the puncture site. Do you agree?
Yes.
Okay, so let's cut here. So one thing here we were talking about, I don't know if they were cutting in the, this patient, they said she had a pre-cut, so, but we didn't see any evidence of that. Can you, Bo, yep.
Was the orifice sort of fibrosed, Mouen? Was it pretty hard, or?
The what?
The orifice.
No, it wasn't. I mean, it went in pretty easily.
Another thing for the audience that we talked about yesterday, in the presence of a periampullary diverticulum, I tend to limit the size of my sphincterotomy, staying well within safety limits, and if I need to go further, then I'll balloon dilate it. So I'll augment it with balloon dilation rather than extend the sphincterotomy to its full limit.
And, you know, if this patient, if she has anything, she has a little stone, so there's no need to be aggressive. So the only other thing is, I think I will want to perform a sphincteroplasty in a patient like this whose gallbladder is going to stay in. I tend to perform a sphincterotomy and a sphincteroplasty. In case another stone passes, then it just doesn't get impacted in the bile duct.
Remind me, are there stones in the gallbladder, or is this patient doesn't have stones?
You know, on this imaging here that we have right now, it doesn't look like we do. So let's exchange, and then I will take a 12 millimeter balloon for sphincteroplasty. So the duct is about 12 millimeter, so we're gonna just dilate to the diameter of the duct. Go. No, 10 to 12. And after I do a sphincteroplasty, then we're going to sweep the duct, and then we're done. So I don't know if we talked about it. So initially for extrahepatic rendezvous, really the most important thing is your puncture angle. The head of the scope should be pointing towards the ampulla. Otherwise, it's going to be very hard to get the wire to go down towards the ampulla. There have been reports in puncture.
Mouen, is it, even with your good angle, you still had just a little bit of difficulty. So it's important to have an angled guide wire that's torqueable. Is that
very, very important? And you see how it took a little bit of work to rotate it and to go downward. So yes.
Mouen, Dongwang CEO has a question. Hopefully you can hear him.
We can't hear you well, so if you can just be a little louder.
Hello? Can you hear me?
Yes.
Can you hear Dongwang?
Yeah.
Yes, he is. He's listening.
We can hear you better for sure.
Very much. It's really fantastic.
Okay, let's
One thing I'd like to ask is, initially you made puncture in the CBD and you injected contrast. And as Rob mentioned, that the shape of CBD and the pancreatic duct was quite funky. But during this ERCP and injection of contrast, we cannot see those kind of different shape. So what made this difference? I'm just curious.
Yeah, so the distal duct was very funky for sure, and now it looks straight. I can't explain that. It has to do with the diverticulum. That's the only thing. So whether the diverticulum shape changed with our scope being in D2 with our insufflation, but I would...
cholangiogram, did you see pancreatic duct also?
no, but we're gonna inject soon.
We got some pancreatography when we are doing the...
Yeah, what he's saying is now when we injected, it didn't go to the pancreas.
Okay.
Yeah. Is this 12? Go to 12, please. So here we're just going by the diameter of the duct, and this is pretty safe as long as you don't exceed that. And we talked yesterday a little bit about how long do we dilate for. I really believe it matters more in patients who get sphincteroplasty without sphincterotomy, because the longer the dilation is, the more separation between the ducts, the less risk of pancreatitis. Once we do a sphincterotomy, you separate the ducts, this becomes a little less important. But I usually do a minute. So now we're at 12. We're just gonna hold it for a minute. Minor bleeding is common after sphincteroplasty.
Mouen. Yes.
Yeah.
So very nice demonstration. Thank you very much.
Okay.